Hi all, welcome back to Emergency Medicine lecture series. In the today's video, we are going to learn about wound evaluation and initial management in the ED. I am Dr S Prakash Babu, Associate Professor of Emergency Medicine at Karpaganaga Institute of Medical Sciences and Research Center. The course objectives for today's lecturer, we will be learning the basic principles of wound evaluation and management, the medical legal aspects related to wound management, either in the initial stages or the follow-up stages, history and wound examination, assessing the risk of infection and need for any tetanus prophylaxis or antibiotic prophylaxis, and how are you going to manage the wound in the initial stages. So aims and objectives of wound management include, the first and foremost is to eliminate any dead tissues and preserve healthy viable tissues, achievement of proper reepithelialization and wound closure for cosmetic purposes, reduction or elimination of wound tissue inflammation, infection prevention, and control of the wound area. Coming to the medical legal part of wound management, 20% of medical legal claims and 10% of all settlements in the US are related to in one form of wound management. First of all, let us look at who is responsible for wound care. Wound care is usually not a single person's job or a single specialist job. All the medical personnel who have attended the patient, right from the emergency physician and the emergency nurse up to the level of a surgeon or an orthopedician, is responsible for wound management, and they can all be sued. Problematic areas of wound care in respect to medical legal cases include usually the correct identification of wound etiology. Usually people fail to obtain a proper history and identify the etiology of that has caused the wound. Treatment based on evidence-based best practices and appropriate local wound care. An accurate assessment of a risk with an appropriate plan and documentation of care are usually required in wound management, which will save you from any medical legal complications at a later date. So the basic principles of wound management include, first and foremost, we need to reduce bleeding by achieving a proper hemostasis so that the patient's life is preserved. Remember, always life takes precedence over a limb. So preservation of life is best effort. So hemostasis comes first in any wound management. You need to properly classify the wounds for documentation purposes and document appropriately. Assessment and modifications of risk factors is important. Infection control in the wound cleaning and appropriate debridement and dressing, oxygenation and moisture control in the wound environment, appropriate analgesia for the patient, skin wound closure, nutritional support, adjunct therapy all take precedence. These are the basic principles based on which you are going to manage your wounds. So first and foremost, let's look at how you are going to achieve hemostasis. The initial step in wound management is stopping the bleeding. Hemostasis helps in reducing blood loss and allows proper wound assessment. This can be achieved by pressure application, direct digital pressure, or pressure dressing. Limb elevation, wound closure. Physical means of applying pressure to bleeding include use of gelatin, cellulose, or collagen sponges. Place it directly into the wound. The bleeding is continued even after digital pressure application or placing gelatin or cellulose. Chemical hemostasis using epinephrine mixed with the local anesthetics in concentrations of 1:1 lakh or 1:2 lakh can be injected into the wound area to achieve the capillary oozing. Torrential bleeding may require application of tourniquets, which might endanger the limb, but it preserves the life. Coming to wound classification, wounds can be classified into 4 classes based on the features of the wound. Class 1 wounds are closed or clean surgical wounds and no chances of infection in class 1 wounds. Examples: a clean surgical incision under proper aseptic conditions. Class 2, also called as clean contaminated wounds. There are no signs of infection as such, or there are no inflammation, but they involve either GIT, the respiratory tract, or the genitourinary tract, where there are organisms loaded inside the lumen. When you enter these cavities, even if you are doing in an aseptic environment, you are going to create some form of contamination. So they are called clean contaminated wounds. For example, tonsillectomy wound. Class 3 are usually contaminated wounds. They are the result of open injury with visible contamination, like household injuries, operations with major breakdown of sterile technique, and spillage of GIT contents. Class 4 wounds are called dirty contaminated wounds. They are visibly soiled with foreign bodies, dirt, and debris. Examples include road traffic injuries contaminated with feces or pus during surgery. What are the historical points that you need to concentrate and specifically obtain during the initial stages of wound management? First of all, you need to assess for potential for infection, ascertain tendency of patients to form hypertrophic scars or keloids. This becomes a medical legal issue if you have not properly taken this history and informed the patient about their tendency to form keloids, especially over visible sites like the face, the arms. The patient might sue you in the court of law saying that you didn't achieve a cosmetically good looking wound. You need to obtain detailed history of allergies and prior adverse drug reactions to especially anesthetic agents and all the drugs whatever you are using that prevents any untoward allergic manifestations and anaphylaxis. Determine the status of prior tetanus immunization to decide whether you need to give tetanus prophylaxis or you can withhold tetanus prophylaxis. You need to review the mechanism of injury to identify presence of contamination and foreign bodies, determine the exact time of injury and the time elapsed between the time of injury to presentation to you. So some of the specific points that you need to note down in the history include pain score, the extent of the swelling, any paresthesias, if there is any nerves involved, and muscle weakness to look for any nerves involved in the wound. Type of forcing causing the injury, whether it is a crush, blunt, or shear by sharp objects, bite, or puncture. This becomes medical legally important. Elements of wound contamination like time elapsed from injury until initial cleansing, time elapsed from injury until presentation. Initial cleansing would have done either by the EMT personnel when they have arrived at the scene or in a primary healthcare center where they would have done initial cleansing before referring to the tertiary care center. The time elapsed from injury until presentation is when you have seen the patient for the first time and when the injury has occurred. Wound care performed prior to ED arrival is very, very important because that determines the prognosis of the wounds. Objects that cause the injury, glass, wood, which can lodge into the soft tissues and they will act as foreign bodies. Unless you remove those foreign bodies, the wound is not going to heal. Cleanliness of the body and the environment at the time of injury and afterward is very, very important. Factors resulting in injury, either intentional or unintentional, occupation or non-occupation related injuries, assault or self-inflicted injuries, all these are medical legal importance. Foreign body potential, did the object break or shatter when it has caused the injury? Any foreign body sensation within the wound, removal of portion of object from the wound, increase the chances of having a larger foreign body inside the wound. Function of the limb where the injury has occurred, occupation and handedness of the patient, which will determine your future management. Any medications that the patient is on or any medications that the patient has taken following the injury, chronic medical conditions that increase the risk of infection, chronic medical conditions that increase the likelihood of poor wound healing and previous scar formation, as I told earlier. So now let us look at what are the risk factors for wound infection. The risk factors for wound infection can be divided into the wound related features and the host factors. Wound related features include location, the wounds over the leg and thigh, arms and feet, then chest, then back, and then face, and finally scalp have high propensity for injury. Infection. Contamination with devitalized tissue, foreign matter, saliva, or stool that is present increases the chances of wound infection. A blunt mechanism where it has caused more damage than that is actually visible. Presence of subcutaneous sutures. Type of repair risk is greatest for sutures, which is greater than staples, which is greater than taping. Anesthesia with epinephrine also increases the chances of wound infection and delays healing. High velocity missile injuries cause more serious injuries and delayed healing, and infection chances are increased. Coming to the host factors, which are the risk factors for wound infection include extremes of age. You know, healing is delayed both in young age and the elderly. Diabetes mellitus is particularly a chronic disease which impairs wound healing. Chronic renal failure, the immune system is deranged. Obesity and malnutrition, the use of immunosuppressive medications, presence of connective tissue disorders, and protein and vitamin C deficiencies all delay wound infection, thus increasing the chances of infection. Coming to wound examination, you need to follow a proper technique for wound examination. Adequately anesthetize the tissues for proper evaluation of the wound. Carefully probe the wound to determine the depth injury to the underlying structures. Proximal arterial control to create a bloodless field aids in examination. Check the range of motion of joints distal to the wound, especially in the hands and the feet. Sterile gloves may not be necessary as part of the wound closure. There are minimal diagnostic testing that you can perform before managing your wound. Wound imaging helps in detection of foreign bodies. Plain radiography will detect glass foreign bodies in about 70% of cases, metal in 99%, wood in 7% of cases. CT and MRI are useful for identifying and locating objects that have densities similar to soft tissue. Ultrasound may also be useful, particularly for wooden foreign bodies. Sensitivity of ultrasound is inadequate to reliably exclude small foreign bodies which are less than 5 millimeters in size and wood fragments. Anesthesia. Adequate anesthesia is important for patient comfort and cooperation. Now, many cases of doctors being sued because the patient didn't feel comfortable or pain was not adequately reduced during the examination. So take care to give proper anesthesia or use appropriate analgesia. Regional anesthesia is preferred for wounds innervated by single nerves, especially in the limbs. Infiltration may cause swelling and distort the wound anatomy. So withhold infiltration as far as possible. Go for ultrasound guided regional nerve blocks. Neurovascular examination should be done before and after giving any form of anesthesia. Procedural sedation may be needed for uncooperative and apprehensive patients. Irrigation. Irrigation decreases bacterial count and helps remove foreign bodies and debris. Choices in the performance of wound irrigation include solution composition, temperature of the irrigant, pressure with which it is applied, and the total volume used. Sterile normal saline is the most commonly used irrigant. Potable water is as effective and cost beneficial compared to normal saline. Solutions of povidone iodine and hydrogen peroxide should not be used as they do not confer any greater benefit. Moreover, they cauterize the tissues, delay wound healing, and increase the chances of wound infection. Polyhexanidine has been tested extensively and has been shown to reduce post-repair infections, but it is not a cost-effective High pressure irrigation at pressures greater than 7 psi reduce wound infection in class 4 wounds. So these two can be combined together to reduce any chance of wound infections. Foreign body removal, one of the most important part of dealing with a wound. The risk of retained foreign bodies is increased in patients with head or foot wounds. Such wounds sustained in motor vehicle collisions or puncture wounds due to shattering of glass pieces. Clinical clues to their presence include a foreign body sensation within the wound, a point tenderness, or increased pain and range of motion. Carefully assess for foreign bodies either using an X-ray or an ultrasound, and carefully remove obvious foreign debris. Despite careful examination and imaging, 4% of foreign bodies are still retained in superficial wounds. So educate patients accordingly and take their consent for any to avoid any further complications, medical legal complications. Coming to debridement, non-viable tissue in the wound increases the risk of infection and delays wound healing by acting as nidus for infection. Debridement is the process of removing non-viable tissue. It serves the dual purpose of removing foreign matter, bacteria, and devitalized tissue and creating a clean wound edge which can heal properly. Excisional debridement targets tissue that has a narrow base, has irregular devitalized edges, and lacks any capillary refill. Prophylactic antibiotics. There is no evidence that routine prophylaxis prevents infections. Traumatic wounds repaired in the ED have 2 to 5% risk of infection. Antibiotic prophylaxis for traumatic wounds in an ED should be initiated before significant tissue manipulation is done, performed with agents that are effective against predicted pathogens, especially polymicrobial, and administered by routes that rapidly achieve desired blood levels, usually by IV route. Non-bite wounds, beta-lactam antibiotics for 3 to 5 days is the prophylactic of choice. For human bites, amoxicillin clavulanate is the drug of choice. For other mammalian bites, amoxicillin clavulanate holds good. Coming to tetanus prophylaxis, wounds can be divided into clean minor wounds, dirty puncture wounds. For clean minor wounds, immunization status is unknown or less than 3 doses have been taken. Give only DTPA. The patient has taken last dose 10 years back. Again, give DTPA. Greater than 3 doses and less than 10 years since the last shot, no prophylaxis is needed. For dirty puncture wounds, immunization status is unknown or less than 3 doses have been taken. Need to give both DTPA plus tetanus immunoglobulin. Greater than 5 years since last dose, give DTPA. Greater than 3 doses and less than 5 years since last shot, you don't have to give any prophylaxis. Adjunct therapies include hyperbaric oxygen therapy, which increases oxygenation and prevents infection. Electrotherapy reduces the devitalized tissue and creates a clean wound margins and enhances healing. Negative pressure wound therapy and topical recombinant growth factors can be used to promote wound healing. Greater is the art of beginning, but greatest is the art of ending. Thank you. Please don't forget to subscribe and share the videos, provide a dissemination. Thank you once again.